All right, so today we have our session on treatment of co-occurring trauma in SUD, and we have Lander that is presenting. So, Laura, if you would like to go ahead, you are welcome to share your screen and start your presentation.
Okay. All right. Can you guys see that?
No.
No. Okay.
Nope, don't see anything yet.
There we go.
Okay. Good. So I'm Laura Lander, social work faculty in the Department of Behavioral Medicine and Psychiatry, talking about co-occurring trauma and substance use disorders today. And again, if people have questions, I know Kelly and Chantry are going to help me with the chat. I'm happy to be interrupted instead of just talking straight through. And if people have case examples they want to share during the course of the talk, that's good too. So just starting out with a little bit of a definition of trauma. So it results from an event series of events or set of circumstances that an individual experiences that is physically or emotionally harmful or life-threatening. And it typically affects mental, physical, social, emotional, and even spiritual well-being. A lot of the times when we think about traumatic events in people's lives, at least most of the people I see, they do not have a single traumatic event. They actually have what we call complex trauma, which is exposure to multiple traumatic events, often starting in childhood. And this has a layering effect. And when traumatic events start in childhood, it actually has an effect of really altering people's brain development. And so when we think about co-occurring substance use disorders and trauma, this is often what can predispose someone to developing a substance use disorder if the traumatic events occur first. So someone shared, actually Tierney Leary shared with me this particular definition, which I love, and it's great for kids as well as, people who don't need a whole bunch of words when we explain trauma, which is trauma is too much all at once, too much for too long, or not enough for too long. And I love this explanation because it can be one of these things, or it can be all three of these things, or with complex trauma, it can be all three of these things at different times during people's lives. But I particularly liked this, so I wanted to include it. So trauma is, a physiological phenomenon. People's bodies can experience trauma. People's brains process that trauma in different ways. And then a psychological event. So when we think of childhood trauma can impact attachment early in childhood, especially if we think about a child being removed at the time of birth due to interuterine exposure to substances. That is a traumatic event both for mother and child and impacts attachment. It can cause mood disorders, so it can cause PTSD or other kinds of mood disorders and predispose people to having a really hard time managing emotional states. And it can cause behavioral disorders and behavioral dysregulation. So I wanted to just talk a little bit about the evolution of the diagnosis of PTSD. So not everyone who has experienced a traumatic event develops PTSD. And we'll talk a little bit about the percentages, the incidence and how many people actually do and who's more predisposed. But in 1980, there was really a shift in the understanding of the etiology of trauma and PTSD. So it's one of the only diagnoses that require an event as part of people's experience in order to have the diagnosis. So it has to be a traumatic event. So that in that way, it's really unique, and it's called the stressor criterion. But in DSM-5, We actually have these four categories of symptom criterion, which I really liked this shift in the diagnosis and the way that we use criteria to diagnose. So the symptoms basically fall into these four categories of intrusion symptoms, avoidance symptoms, cognition and mood symptoms, and arousal and reactivity symptoms. Uh, and so these can be anhedonic or dysphoric presentations. And so when we think about how many people have trauma, and even why is it that some people develop trauma, PTSD, following a traumatic event and other people don't? So about 70% of individuals who experienced at least one traumatic event in their lifetime, that's most people, obviously, depending on how old you are. It makes it more, if you're older, it makes it more likely that you've experienced a traumatic event, but only kind of 19 to 4% of people develop a diagnosis of PTSD. Depends a little bit on the kind of trauma. So sexual trauma and interpersonal violence have the highest rates of individuals who go on to develop PTSD, and it's higher in females than in males. And then if people have multiple traumatic events or complex trauma, people are more likely to develop PTSD symptoms. So trauma is very broad, and it often gets the word trauma gets overused in our speech. Everything that is uncomfortable is not a trauma. And so I think we need to be a little bit careful about how we use the word. Trauma is often self-perpetuating, so people who've experienced trauma can be more likely to perpetuate that and to perpetrate that. But we need to be very careful about assuming that someone who has a history of, say, childhood abuse is going to go on and abuse their own children. Often people take great pains not to do that and gain skills specifically not to do that because they do not want to perpetuate that trauma. Trauma affects the way that people approach potentially helpful relationships. So trust issues are impaired, especially if people experience trauma at the hands of their primary attachment figures or people that they have trusted. So it makes it hard for them to trust us as healthcare providers. And trauma affects staff members as well as the patients that we work with. So we think of that as secondary trauma. We often hear extremely disturbing and painful stories that our patients tell us about the things that they've experienced. And that in and of itself can be traumatic, especially I'm a very visual person. So if I get images in my head of the things that people tell me, those are often hard to get out of my head. And people want to share any experiences with that or ways that they cope with that. We can certainly talk about that. So just like to kind of touch on trauma over the lifespan. So it often starts at this foundational level of adverse childhood experiences, and that then impacts people's brain development. And we'll talk a little bit about the impact of trauma on the neurodevelopment in the brain. And then that impacts social and emotional and cognitive functioning, including relationships and the quality of relationships that people can have and the regulation that people have over their mood. And then people engage in risky behavior that further puts their health at risk. And then this, obviously, disease and early death can occur as a result. Everyone is familiar with ACEs, so just a little review of adverse childhood experiences. These are the general ones, and these are the percentages of people can read that. So substance use, growing up in a home where there's substance use is the most common adverse childhood experience. And then these are some of the things that happen with when people have high ACE scores. They are associated with all of these negative outcomes, like more likely to smoke, more likely to have obesity, use substances, attempt suicide, et cetera, et cetera. And there's also a whole host of medical conditions that are also associated with having ACEs of over 4. When ACEs first got ACEs have been around for a long time, and then they kind of made a resurgence, I think, during the opioid epidemic, and we began to talk about them more. So everyone usually has taken their ACE score and has a sense of what their own ACE score is. And we did this with our patients in our COAT clinic. And these were the results that we found. 54% of individuals in our COAT program had 4 or more ACEs. Females almost more than 1 greater than males. So again, we see that playing out in our own population, that women are more likely to have traumatic events occur in their lifetime, and pretty high rates of physical and sexual abuse. So this is probably very similar to the folks that you guys work with. So what is the prevalence of co-occurring PTSD and substance use disorders? About 44% of people with PTSD meet criteria for alcohol use disorder or another substance use disorder. And it just increases, if someone has PTSD, it increases the likelihood that they'll have a substance use disorder. About 2 times as likely to have an alcohol use disorder and 3 times as likely to have another substance use disorder. There's a really interesting study that has multiple publications. It's called Project Harmony. So I've cited a couple of them in the references, and it's really a meta-analysis looking at multiple randomized controlled trials about the psychological and pharmacological treatment for co-occurring substance use disorder and PTSD. So if anyone is interested in some additional reading, I would direct you there. It's a very large meta-analysis. And what it ultimately says is it is best to treat both at the same time, not treat one first and then the other, which is challenging, especially if people do not have a lot of sobriety. And so building skills to manage psychological symptoms that often people are using substances to manage is a really important component of that. So how does trauma affect the brain? This is an MRI scan of a child who experienced severe neglect. And so literally all kinds of neurotransmitters are different in the brain of someone who's experienced trauma, as well as decreased brain matter. And this is a complex slide, and you guys can, I'm not going to spend a lot of time on it, but it'll be in the slides that are sent afterwards. All kinds of areas of the brain are significantly impacted by trauma. So we think about the amygdala. So this is actually the area in the brain that's responsible for emotional functioning. But people's amygdalas are literally larger who have PTSD. And especially those who've experienced trauma in childhood and have complex trauma. But it affects neurotransmitters in the brain. It affects communication between the regions of the brain, much like substance use disorders. So there's really almost like a parallel in the way that trauma and substance use affect the brain. In particular, the locus coeruleus is affected, and we think of that when we think of some of the symptoms that we see, like the overstimulation or the flooding that people experience, the triggers that people experience, either to visual cues or to auditory cues, or even to behaviors in other people. So it's theorized that trauma memories get stored in the amygdala, and the retrieval process is actually different, which is why people have this, flashbacks, for example, and intrusive thoughts. And then the parasympathetic shutdown results, and that can cause dissociation and numbing. And then the hyperarousal is on that hypothalamic pituitary adrenal axis. So again, sometimes we wonder which came first, the trauma or the substance use disorder, and it actually varies. There are some risk and protective factors for both. So for both substance use disorders and trauma, there are genetic risk factors. age is a risk factor. So for substance use disorders, the earlier the onset of substance use, the more likely someone is to develop a substance use disorder, and the same for trauma. So the earlier onset of trauma, if there are the more episodes of trauma someone experiences, the more likely they are to be diagnosed with PTSD. Childhood adversity, physical and psychological trauma, pre-existing mental health conditions predispose people to substance use disorders, and substance use disorders make it more likely that someone might experience traumatic events as well as develop a substance use disorder. Social isolation, we know, contribute negatively to both as well. And then protective factors are those social supports. So really combating isolation and having a place to go with discomfort and stress. Finding positive meaning in the trauma. So that's a lot of the work that gets done with narrative interventions for the treatment of trauma and PTSD. Identifying it as a survivor as opposed to a victim. Again, when we think of cognitive behavioral therapy and the thinking that can precipitate change in people's PTSD symptoms. Having an internal locus of control versus an external locus of control. And then people's families' response to trauma and substance use disorders. So if you have a family that blames you for your behaviors that are symptoms of your PTSD or blames you for your behaviors that are part of your substance use disorder, people will have a different experience than if the family says this is actually part of a process, a disease process that people can get treatment for and can get well from. So we'll do a little bit about assessment. There are many, in my opinion, people who get misdiagnosed for having all kinds of things when actually what they have is PTSD or certainly have experienced trauma. So we see an overdiagnosis of people with trauma and substance use disorder of bipolar disorder. Now, there are certainly people who've experienced trauma and have a substance use disorder who do have bipolar disorder, but oftentimes if that diagnosis is coming in the context of active use or when someone's very dysregulated from their PTSD, it can look like bipolar disorder, and it's actually not. The other differential diagnosis that I think about is borderline personality disorder. So people definitely have borderline personality disorder who have experienced traumatic events. That's really almost a precursor to that diagnosis. But also it may be that they get misdiagnosed because they actually are experiencing PTSD and people are confusing it for a personality disorder. So it's a little bit tricky in terms of diagnosis. There are lots of different assessments, a couple that are listed here, the clinical administered PTSD scale, the CAPS, International Trauma Questionnaire, PTSD checklist. The VA has great resources on their websites about using assessments to diagnose trauma. And then these classic areas of assessment like demographics, health, family, childhood, peers and relationships, or other kind of qualitative areas to be sure to assess. Again, these are these domains that I mentioned that are part of the DSM-5 diagnostic criteria, and the list of what symptoms fall under each domain: the intrusion, avoidance, cognition and mood changes, and arousal and reactivity changes. For me, the new diagnosis is new, 2013. The newer diagnosis, the diagnostic criteria seem a little bit confusing until I put them into these categories, and then they feel a little bit easier for me to assess for, because there are really so many ways that PTSD symptoms can occur. So this is the chicken or the egg question. And there are a couple of different models. There's a causal model, a self-medication model, and a shared liability model. The causal model is that when we think about the interconnection of substance use disorders and trauma, that substance use disorders actually, if someone has a substance use disorder, it increases the risk that people will put themselves in a situation where they have a traumatic experience. So the classic is, people become intoxicated and they get physically or sexually assaulted. So it comes directly as a result of them not being able to take care of themselves when they are intoxicated. So that's kind of the causal model. And then the self-medication model is that people actually use substances to cope with past traumatic events. So it's more that they've found it as a way to function. And so that would indicate that the trauma came first and the substance use disorder came second. And then there's this shared liability model, which is kind of a mix of things come both at the same time, which is people who have higher ACEs, whether they have PTSD or not, really have a vulnerability to both developing PTSD and substance use disorders. So I'm not saying one's right or one's wrong. They're just different models and ways of looking at the interaction between the two. So any questions or comments in the chat before we jump into treatment? So I'm going to go over the evidence-based treatment. Really, these are mostly evidence-based treatment for trauma, and also are really effective treatments for substance use disorders as well. So when we think about how to treat both at the same time, people absolutely need skills in order to find another way to manage their PTSD symptoms. Because once they have both, doesn't matter which came first, when they come to us for treatment, in some ways, how do we give people some release or some tools to improve their experience of living? Really giving people some skills is going to be important. And doing that in a setting that feels safe. So a couple of slides on trauma-informed care. So this is by, Fallett really created this model of trauma-informed care, and it, as people may know, it includes not only what happens in the therapy office, but what happens from the moment that the person walks in the front door at our agency. So I often joke that when people come into Chestnut Ridge or Healthy Minds Chestnut Ridge, they encounter security and a metal detector. This is not trauma-informed care, or it doesn't necessarily appear to be trauma-informed care. And when we had this put in our building, there were lots of therapists who were very concerned about how patients would experience this, including, men doing a wand on their body to see if they had any weapons. I mean, there was a lot of concern, and patients certainly had a tremendous amount of discomfort. I would also What we talked about is also suggesting to clients that the reason that we have this is to try and create the safest environment that we can inside the building. So there will be no one in this building who has a weapon. And so while that may not necessarily reduce their discomfort as they go through the metal detector, it may mitigate some of that discomfort once they're actually in the building. So the 5 core values are safety, trustworthiness, choice. So giving patients a choice about treatment providers, about where they sit in the room. All choices can be at all kinds of levels, about choice of waiting room, as much as we can, depending on our setting, giving people as much choice as possible. Collaboration, thinking about the therapeutic engagement and process as collaborative versus us being the expert, and them receiving from us, that it's really more equal, so that we can empower people to be part of their own health. He identified the 3 E's and the 4 R's as part of this trauma-informed approach. And the 3 E's being the events or circumstances around the trauma. So making sure we have a sense of that, not just understanding or knowing the traumatic event itself, but the circumstances before and after. the experience. Often it's the experience and the story someone tells themselves about the traumatic event that determines whether or not they develop PTSD, and then the effects of trauma, which can include physical, social, emotional, or spiritual consequences. And then the 4 Rs are part of creating a trauma-informed experience for clients as much as possible, understanding that at all levels people have a basic realization about trauma and how it can affect people, and that varies depending on the person. So my realization about that may be different than my clients, and I want my client to share with me what theirs is, not what I think theirs is. We want to recognize that people sometimes are aware of their signs and symptoms of trauma. Sometimes people's family members are, sometimes they aren't. So who's aware? What does it look like to other people? And what's the level of the client's awareness themselves? Response. So this is really institutional. It can be an institutional response. It can become community response. It can be a caregiver or a healthcare provider's response. We want to respond in a trauma-informed way at all levels. And then resist the re-traumatization. And that was how the metal detector was really, the concern was that we are re-traumatizing clients as they walk in the door to receive treatment from us. And so as much as possible, we want to reduce either that if it's intentional or unintentional. And then the specific treatments. So if anyone's not read this book, it's pretty amazing, although it's sometimes hard. It was sometimes hard for me to read because it is individuals' descriptions of some of the trauma they've experienced as a result of their substance use disorder. But it's a wonderful book. And it says, we create meanings from our unconscious interpretation of early events, and then we forge our present experiences from the meaning we have created. Unwittingly, we write the story of our future from our past, from narratives based on our past. And this is actually a point of intervention, is, again, when we think about a narrative intervention for PTSD, the ways that we can help people change the story that they tell themselves about the meaning of past traumatic events, including the development of their substance use disorders. So these are based on the American Psychological Association's evidence-based treatments for co-occurring substance use disorder and PTSD. So primarily, we're talking about PTSD here, and PTSD when people also have substance use disorders. So CBT, cognitive processing therapy, prolonged exposure therapy, EMDR. Now, I know that the protocol for EMDR is you're not going to necessarily do EMDR when someone is very, very early on in recovery and has limited to no sustained sobriety. Usually it's at least 30 days of sobriety before EMDR would begin, because people have to have some, we don't want people doing EMDR certainly when they're intoxicated. We don't want anyone doing any therapy when they're intoxicated. Narrative exposure therapy. Seeking safety, there's some evidence it's not quite as strong as the first line or second line. Seeking safety is a treatment that was developed for women who've experienced interpersonal violence and substance use disorders. And then relaxation techniques. So we often will use relaxation as part of our intervention, maybe even as part of mindfulness interventions that we might use. And these are the medications that are typically recommended. So I recently learned about NAC, which is N-acetylcysteine, which I'm probably pronouncing wrong. So is anyone here a prescriber that prescribes this for people in their practice?
I've tried it for cannabis use disorder, but not for other stuff.
Yeah. And it has shown when we heard for anyone who went to ATI, they talked about this as a medication that actually has shown really quite promising efficacy for adolescents for the treatment of cannabis use disorder, which is amazing. Because when we think about, most of the adolescents that come into treatment, especially 14, 15, 16, their primary substance of choice is THC. There's this debate about which are better, unimodal or phased-based kind of treatments, and here's a list of what generally falls under each one. So when I think about EMDR, people know that's definitely phase-based, and the early phases are really about resourcing and grounding. There is no clear evidence that one is better than the other, the unimodal approaches versus the phase-based approaches when they compare them head to head. And that's what that study was looking at, the systematic review at the bottom. So these are all effective treatments. So I'm not going to go through these in great detail, but there's kind of a slide on each evidence-based treatment. People are usually pretty familiar with trauma-focused CBT and the components being psychoeducation, really about what trauma is, the symptoms of trauma, how trauma affects the brain, and then relaxation and stress management, and how to manage and regulate emotions, including identification of emotions as kind of the primary components of that treatment. Cognitive processing therapy is another treatment that has strong evidence basis, and it's really kind of cognitive therapy plus exposure therapy through writing and reading rather than going out and doing environmental exposures. So again, there's similar components, psychoeducation around PTSD, thoughts and emotions, and really beginning to unpack the beliefs maintaining the PTSD symptoms, which I sometimes say, talk about as the story that we tell ourselves about the situation or the traumatic event, and then really using writing and reading to reshape or reform some of those beliefs that then get shared with the therapist. Prolonged exposure therapy. So this is typically a manualized based treatment. One of the primary ways of coping, substances is one in terms of dealing with PTSD, avoidance, which substance use can be a means to an ends, to avoidance of feeling, avoidance of remembering, avoidance of re-seeing or having flashbacks. So people are actually encouraged on a hierarchical scale, starting with the least disturbing or distressing first, to begin to lean into the symptoms that they're experiencing. Again, you can use imagining, writing, or even visiting the place where the traumatic event has happened. Again, VA has done a lot of research on prolonged exposure therapy. And as people tolerate the exposure to these traumatic triggering situations, they slowly kind of increase their exposure to ones that might be more difficult. EMDR, so their EMDR has 8 phases, and so this is one of the phased treatments we think about before people are doing actual bilateral stimulation. There's a lot that happens in the history taking, preparation, assessment phases. And the idea is installing a new cognition. So I'm not trained in EMDR, but it's interesting when I talk with colleagues who are doing EMDR, one of the things that's really interesting as they talk about their experience as clinicians is that the secondary trauma is much less because people are not telling you the story of their traumatic events. They're experiencing that internally while they're having bilateral stimulation, but the therapist themselves does not actually have to hear the details of the story, which can be part of other reprocessing therapies. narrative exposure therapy, so very similar to some of the others that we talked about. Often people will do a timeline with this intervention and really describe the thoughts, feelings, sensations, and memory associated with it. Again, starting with the least disturbing first, so that you work up a hierarchy before you have people tackling the more disturbing memories or sensations. The idea is to promote integration, personal identity, and develop schemas and self-respect and reduce blame. Many patients blame themselves. That may have been part of the grooming, say if they were a child and have childhood sexual abuse, that they were told they were at fault for the abuse, or they had a family member's response to when they disclosed abuse, they were told that they were somehow at fault. And so narrative exposure therapy can often really help with that. DBT for PTSD, there's also DBT for AT, and they can be integrated. So using the 4 skills in the 2 categories of acceptance and change, the skills being mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. So this has a little less research than the ones that I just discussed before, but I think are very effective for the treatment of co-occurring PTSD and substance use disorders. And then we have the classic talk therapies, supportive therapy, including relaxation, teaching anger control skills, generally improving people's habits, eating habits, exercise habits. Exercise, we know there's some very effective interventions for people with substance use disorders. The problem is getting people to do the exercises. Adherence to those treatments can be challenging. But contingency management can also be part of those interventions. And the goal is really to help people deal with the guilt and shame around both trauma and substance use disorders, because guilt and shame are really a big part of both experiences for most people. So I wanted to just mention some of the more experiential therapies. When people have pre-verbal trauma or do not have any specific memories of their trauma, but they have body sensations, or they have reactivity, but without a specific memory of the traumatic event, other kinds of therapies can be really helpful. And so we think of these as expressive therapies. So psychodrama, which is more of an acting out of traumatic events and getting people to play roles that are part of the traumatic event and promote healing in that way. Meditation, yoga, mindfulness-based stress reduction, Tai Chi, and then all of the experiential therapies like music therapy, art therapy, animal therapy, where people aren't necessarily talking about their trauma, but they're having, so there's like the example of this trust walk, they're having experiences where they are building trust with another person. So in my very first job, I got to do basically adventure-based counseling is what it was called, and where we did the ropes course. We've done that in here at Chestnut Ridge and to a certain extent Center for Hope and Healing, where people really get to be in their bodies, experience stress if they're high up and they're afraid of heights. And it's all kinds of these evidence-based therapies, in my opinion, rolled into one. So there's some exposure to distress, moving through that with the help of others, and usually there's some verbal processing after the experience. Other treatments, psychedelic-assisted therapy is getting a lot of attention, still a little bit understudied, so there needs to be more study, and there's always the concern that people are engaging in therapies that have either not been well studied or they've not been well trained in doing them. So there's concern of doing psychedelic assisted therapy with people with substance use disorders because there's concern about potential kindling effect and their return to use. So we approach that cautiously. And then people are familiar probably with internal family systems. So this is really the theory that we all have parts and that our different parts carry burdens. It's a really nice non-pathologizing approach because it's like we all have parts, people with trauma and people with substance use disorders. Sometimes the parts are more highly differentiated and less integrated, but this is, something that we all have. It's experiential. So again, another way of working with people where they're not necessarily telling the story, they're going inward to have an experience. They're not necessarily giving us a narrative of the traumatic event. And so for therapists, there can be less secondary trauma. So anyone have an example of someone they're working with who has both substance use disorder and PTSD or trauma? I know you all do, but people may not want to volunteer to talk about it.
I had an interesting experience recently. I was in Upper Peninsula, Michigan, and I met a Native Americans, and I attended one of their wellbriety ceremonies or meetings.
Yeah.
And it obviously a lot of them had societal trauma, the way they were treated. So that was really cool. I learned a lot from the circle thing and how important being in a circle setting is, and the different type of rituals they do. It was a really cool experience, very spiritual.
What can you share an example of like a ritual, a healing ritual?
Well, they have 4 medicines. One's called the sage, cedar, sweetgrass, and raw tobacco. And you move in directions. You move from east to south to west to north, and you hold a feather, an eagle feather, when you're doing your sharing. And they bring an eagle head in there, and it was just that was part of the ritual. And they do the smudging part of the ceremony where they light sage, and then you like put the smoke from the sage on your ears and your mouth and your head to like purification and to get rid of negative thoughts. So it was really good.
Yeah, I love that. Thank you for sharing that, Dr. Gorby. I think the blending of talk therapy and experiential therapy can really help people integrate the talk therapy. It's interesting. Whenever I've done like a time limited group, and ask people to reflect at the end of their time, what stood out to you about, like, say, your IOP experience? What do you remember? They will remember the experiential therapy sessions. They will not necessarily remember what they talked about, but they'll remember the physicality and, when you incorporate rituals in that, I think that really helps. Yeah, that's great. Thank you. Any other examples people wanted to share? So one of my favorite mini psychodramas that I would do, and many of the people that I work with substance use disorders definitely have traumatic experiences, multiple traumatic experience. We would do what was called a family sculpting, where we would stop sharing for a minute, where it was in a group setting and people would, we would do an initial, we would be in a group and then people would choose people to basically represent their family members, and they could choose whatever family members they wanted. Sometimes family members would attend if it was the multifamily group, but they could also choose group members to be their family members, and they would kind of do a still life of their family when they were in active use, and then a still life of their family, how they wanted it to be when they were in recovery. And so proximity, people will get very creative in terms of like how they placed people, like with their arms above their head or angry faces. And there was something really powerful about recruiting their group members into this still life of their family and having it be experiential, that helped the group members understand something about them. It certainly evoked feelings in the group members themselves, like my family's similar to that, or my family's really different. And then to have it be reparative, like how do you want it to be in recovery, but it's like a physical representation of that, not just talking about it. It was always a really different experience when we acted that out. So that's just an example. So just the last thought about secondary trauma, which is defined as trauma-related stress reactions and symptoms resulting from exposure to another individual's trauma experiences. Essentially because that exposure is a traumatic event itself. And so sometimes as healthcare providers, we can regulate for ourselves, and sometimes we can't control, how much is shared, and we can help the patient regulate how much they share with us. And sometimes we can. Early on in my career, I remember having someone do a diary of her traumatic experiences. So we were doing some narrative intervention, and the way that I managed it, I was not able to read all of her diary. I could read small parts and get the gist of it, but I managed the secondary trauma because she had so many traumatic experiences of childhood sexual abuse that I really was. It was not going to be. I was not going to be most helpful to her if I read all of it. But I could read some of it and support her in becoming well and reducing her own symptoms. But it's not always easy to do, and so these internal processing models like EMDR and internal family systems seem to be very helpful in reducing secondary trauma for therapists. Right. Any questions, comments?